So obviously up on the board or up on the wall you can see some fairly high profile major incidents that have happened around the world. And for each of them, we can see that there is an average time which it takes for ambulance services, whether they're in Boston, Manchester or here, to remove patients from scene. The reason that's important is twofold. So one, if you look at the dates, 2005, average removed from scene was 50 minutes. 2013, it was 3 hours, that's at Boston. 2017 was 2 hours. So as we're going up through the years and closer to date, that time is increasing. And you look at the most recent one, which is Manchester, 2 hours 7 minutes for as an average removal from scene time is quite a lot. It's not unusual, but if you're a patient with something that's important that's killing you, that's too long. Okay? So, because of this, and learning that came out of Manchester, and to some extent Boston, but not so much, 10-second triage was born. This is to give you an idea. When did I do this slide? So this was, so these are 2025 figures. So to give you an idea of what the average response time for ambulance services are currently, or as of last year. So you guys will be here, so 7 to 8 minutes if you're in this area. Well, I say you're here because you may get one of us, but 7 to 8 minutes, just over 8 minutes. East have just improved, actually slightly better than that, and then it varies around there. That is for a first resource on scene with a defib. So some of those figures will be community first responders, some of those will be a lone paramedic in a car. None of those when we talk about major incidents and things like Boston Marathon, Manchester Arena, London. That doesn't help with the number of patients that you're going to get here. Okay? Can't remember how many. I was at the London bombings. I can't remember how many patients we had from there. Boston, I don't know. There was about 30 fatalities in Manchester and about 100 and something patients, compounded by the fact they were almost all paediatric as well. So, why is this important? Because from all that we realised, and that's the royal we, that we needed to do something better and something a bit different in terms of triage. So previously with triage, most triage, if not all triage, was done by the ambulance service, and it was done when enough people were there to triage. That varied from time to time. With the London bombings, we hadn't finished triaging for about an hour.
Wasn't Manchester with the numbers that have been delayed because of weren't being allowed on site straight away as well?
So that will compound that. Yeah. Yes and no. So yes, it does. But the findings from Manchester are quite common in terms of the safety response. There was a particular issue at Manchester when it declared it as a Plato incident, which is a marauding terrorist, and then the fire brigade particularly didn't want to go in.
Yeah.
The ambulance service were on scene quite quickly, but not in force, and that was part of the problem. So initially, or pre-2023, people that were doing the triaging were people like me, so the ambulance service, and then we had to get enough people there quickly enough to start that triage and doing it. Some of the learning from the Manchester Arena inquiry and others was that this isn't good enough and it doesn't work. And so from that, 10-second triage was born. And the point of that was to ensure that you've got a rapid system to assess and categorise patients in less than 10 seconds, and if necessary, treat some of the major things that can kill them quickly before we can get them off scene. So if someone's waiting for 2 hours with an airway obstruction, there's no point in someone picking them up after 2 hours. Yeah. And crucially, what 10-second triage does is it allows pretty much all first responders to triage the patients and treat some of the major issues. So TST is now covered by fire, police and ambulance service, and other levels like FREC to respond. Exactly. So how does it work? It's algorithm based. Anyone seen 10-second triage algorithm? No? Okay.
So we've got one in the bag.
Is that the labelling system?
Yes, although it's the new one rather than the old one, so it's similar to that. I've got one up on here as well. So it's algorithmic based system, which means if you can't remember it under stress, You can have it in your hand, you can follow it, and it's relatively simple to follow. It doesn't rely on clinical input, so it doesn't rely on you taking blood pressures, it doesn't rely on you measuring respiration rate, it doesn't rely on anyone feeling for a pulse. It looks for visual cues rather than clinical cues, which means it's very good for what we would call lay responders, so fire and police, in order to triage and treat. And it's essentially, it's a rule in or rule out system. Either it's there or it isn't. If it's there, you respond appropriately. If it isn't, you respond appropriately. The point of 10-second triage is that you are targeting or treating immediately life-threatening conditions within the patients. The reason for doing that is if we don't, they'll die before anyone else can get back around to them. The point of it though is to treat those interventions quickly and move on. So even with the interventions that you're doing, you should be able to see a patient every 10 seconds, is the idea. The reality that you're not going to, but that's the idea. You can be quick enough with the triage that the rest of your, that could be 2 seconds, the rest of your 10 seconds is spent dealing with the problem. So, what do you think constitutes a life-saving intervention in terms of 10-second triage? What can't wait that you need to do so urgently?
Do an airway.
Airway is one.
Catastrophic bleed.
Catastrophic bleed. What do we count as a catastrophic bleed? Because that's a specific. You're right, but there's a specific caveat to that. There's a specific type of catastrophic bleed.
Can be arterial or venous.
Mainly we talk about on
2 hours is too much for both.
True, yeah. So mostly it concentrates on arterial, and mostly it concentrates on the blood being where? Yeah, outside, so it's external hemorrhage. And importantly, particularly for this, it's external hemorrhage that you can compress. Mostly, there are caveats for that. So, plenty of people in blasts will have internal injuries, livers, spleens, they pop, bleed quite nicely. They are catastrophic, they won't wait 2 hours either. 10-second triage doesn't help them.
But
The way it helps them is speed without no intervention.
with the TST, if someone had like a blast, like internal bleeding, you blast, so could be that will be bleeding, talking,
Yep,
even walking.
agreed. Yep. Yep.
So
And we'll go through it in a minute, we'll talk about some of that sort of stuff. Cool. So airway, so someone mentioned airway, so airway comes under it. People with an obtunded airway, i.e. they can't breathe or aren't breathing at all, or very well, they won't survive full on with that. How long have you held your breath for? A couple of minutes, yeah, so if you're completely not breathing, a couple of minutes, and that's on top of injury, so actually that time is reduced. Catastrophic hemorrhage. What about broken bones? Does that count? We're going to start straightening limbs, do you think? 10-second triage?
No.
No, we're going to leave them as they are. Cat tourniquet, you think that's going to go on?
yeah,
Yeah.
of course.
Absolutely, yeah. And wound packing. Has anyone come across wound packing before?
Which called sorry?
Wound packing.
Yeah,
Yes.
that long. Yeah.
Hemostatic calls.
Hemostatic cores, yeah. Where do they go? Where do we use them?
Breathing.
Catastrophic. Deep cuts.
Spurting.
I'm going to say no to all of those answers. Be a bit more specific. So let's say I've got an arterial wound here. How are you going to stop that?
Tourniquet.
Tourniquet, yeah, or? Lost that. Yeah, pressure dressing. So direct pressure on top of that bleed, stop that off. What if my bleed's here?
Yeah, so in that case, then
The wind pattern.
Tourniquet less advised, right?
Yeah.
Yeah. Wound packing, yeah. So that's where your cheeto gauze or hemostatic gauze come in. What about here?
Sounds like here,
Something like that.
over here, yeah, I think so.
Yeah. So femoral arteries, particularly if they get severed, retract up and they can be above the point you can put a tourniquet on. So sometimes packing the wound is the only way to get in. Sometimes it isn't, sometimes you don't reach them at all. Chests are particularly interesting because cheeto gauze is horrible to whatever it touches and it tends to have to be debrided in surgery later. It's not great on your lungs, if it touches your lungs, or your brain for that matter. And the point of it is that it needs to be compressed against something behind it. So it helps, increases the surface area to allow clots to form. but you still have to be able to apply pressure to it. So when you pack the wound, the point is that you pack in, the Cheeto gauze will reach or the hemostatic gauze will reach the point of bleed, and then you will continue to pack behind it until you have pressure, and then that will allow it to pop. With something like your abdomen or your chest, that's almost impossible to achieve because it's a massive cavity. Okay?
So what do you do in that situation?
There's not much you can do. So that depends on what the injury is, but that is rapid removal from scene and surgery by someone either at site or off site. And the point of triaging all these tools is to save as many people as possible. It accepts that there are people that you will not be able to help. Okay. So who can perform TST? So pretty much anyone, any call responder, police, fire, emergency services. And these are the categories that it falls into. So P1 is an immediate, so that's the highest priority that you'll categorise. Requires immediate life-saving treatment, exhibiting time-critical, life-threatening injuries. As you pointed out, they could be people that walk off scene initially as well. So some of your life-threatening injuries won't be picked up by P1s, but most will. Okay. P2, urgent at yellow, needs significant intervention in the earliest opportunity, indicating an inability to walk due to injury or illness. So these are patients that don't exhibit your airway issues, don't exhibit a catastrophic hemorrhage. They're probably awake, but for whatever reason they can't walk away. Okay? And then P3, which is delayed, meaning that in theory they have time to wait. No urgency, and an individual can independently walk to treatment. Okay? Happy with that so far? There is a fourth category, which if any of you have dealt with the old triage system, is a change. So the fourth category is silver, or not breathing. So that's a patient that you come across, they aren't breathing, you do an airway manoeuvre and they still aren't breathing. Under the old system they were designated as dead. Under this system they aren't. They are designated as not breathing. The reason for that is because now police, fire and others are doing the triaging. It was felt it's unfair to allow to get non-medical people, and probably a little bit legally risky, to get non-medical people to declare someone as dead. So they recognise they're not breathing, they will place a silver tag on them, and then when the first medical providers arrive, we will re-triage, and if they're still not breathing, we will probably declare them as dead. If something has changed and they are breathing, or we think we can get them breathing, then we will do something else. Okay?
And that differs from P1.
Say that again?
That differs from P1.
Yeah. So so P1 will still be breathing.
So we breathe.
Yeah. If they're not breathing, then they'll be silver. They'll be not breathing. If you have a choice, if I have a choice in terms of removing who I'm going to remove first from a scene, the P1 will go before the not breathing. And the reason for that is probably whatever intervention you could have done, or the window of opportunity of intervention for patients that aren't breathing at that point has gone. And that's why it's a medical decision rather than a triage decision. And actually that is my job at a major incident, is to make those decisions.
Not breathing means that I can't get already not even try to breathe.
Yeah. Yeah, so there is no breathing. You open an airway, and we'll come to it in a minute, they still don't breathe. And there will be a significant number of these, almost all of these, if they're not breathing at first contact with people, at, let's say, a blast site, for example, they will already be dead. There is nothing anyone is going to do for that group of people. There will be a tiny, tiny cohort that there may have been something that could have been done, but if you spend all your resources on that one person that's got a 1 or 2% chance, you'll miss the 20 or 30 that have much better chances of survival. And that's the reality of trauma, triage in making decisions. When you do it, and you'll see it in your kit, you have a set of bands. These are slap bands, which I think you guys have got. They go on the patient's wrist once you triage them, and then that lets everyone know who's following behind what priority they're at.
By this time the patient is dead.
Huh?
By this time till you find the balance, the patient is dead.
Yeah, well, yeah. Okay. So, here is your algorithm. And you follow it from top to bottom, and it is a rule in, rule out. With only 4 questions really that you need to. There you go.
I knew there was somewhere.
So there's P1s.
Good.
Ben, you've still got the other card you meant to be passing, just FYI. You still
Yeah,
getting
no,
there?
it's just
I've got a different definition of that. I would start with Alan volume. Back off Alan volume, so you've got one of these bands on you.
I've got silver.
Which colour? Yeah.
You can get like this one from McDonald's.
So the way this triaging system is designed is to do it in pairs. Okay. So and you can either challenge and check, so one of you can have the card and read it, and the other person confirms what the patient's doing, or you can both triage independently and ensure that you agree. There's no real set agreement on how you should do it, and it's not really been used enough yet for us to figure out which way works better. First point of call, anyone that's walking is what category? B3, yeah. You walk them off scene, send them somewhere else. Where do they go?
There's usually a
Hopefully.
secondary site set up.
Yeah.
No? Like a,
So they should be directed further back to a secondary
Yeah.
site where clinicians, so ambulance crews will be setting stuff up, and they will undergo a MIT assessment, which is a more detailed triage tool. Okay, so for now, just because they're walking and designated as a P3 in green, doesn't mean they'll stay that way. So you can have a walk-in patient that looks horribly ill, really, really pale, bits of them are hanging off. They are still a P3 because they will get picked up behind you. Okay. If you start making them P1s, what's going to happen?
Number one thing is
Yeah.
too much of
So your P1s that can't walk and can't get out are going to get stuck behind P3s that can. Yeah. And one of the learning points from, where was it?
Manchester.
Yeah, I know, I'm thinking of older than that. I'm trying to think of Russell Square, not Russell Square, that's where I was. So Aldgate. From Aldgate East was the people that survived Aldgate East are the ones that made it up to ground level first, pretty much. And that included at least one guy that carried his own leg up. So he survived because when he got to the top, the ambulance crews that were coming in, he was one of the first people they saw, and he was obviously hemorrhaging from the fact he only had one leg, or he had less than the average number of legs at that point.
Yeah, 2.
Just one was, yeah, one was less useful than the other. So they put a tourniquet on him quite quickly. Had he been downstairs, he would have bled to death. So people walking out is your best chance of survival. You want to help them do that.
And that also will pick up those people who have all those internal bleeds
Yep.
as well, because they'll be off scene somewhere where they can be assessed properly, and you'll pick up on their internal bleeding.
Yep.
So you don't need to worry about the fact that they could have a catastrophic bleed, because they're walking, someone else will pick that up at the secondary clearing station.
So everyone else after that isn't walking, right? So anyone that's walking, go down there, someone will meet you. Everyone else who aren't walking, you need to figure out, is there severe bleeding? Severe bleeding in this context means, let's chat about it right at the beginning.
catastrophic hemorrhage. Hemorrhage,
Yeah.
catastrophic.
So what type of hemorrhage?
External.
External and starts at C. Catastrophic. Yeah. So someone covered head to toe in venous blood that's not really doing much, we don't care. Someone that's got something spurting or a really big venous bleed that looks like more than what they coming out than they should be, that's your catastrophic hemorrhage. Place your tourniquet or your packing, whichever one you think is appropriate. There your P1. Okay? If they're walking, they don't have any severe bleeding, and they're talking to you, The next thing we need to assess is whether or not they've got holes in them that they shouldn't have. So have they got any penetrating injuries? We care a lot about your torso, obviously, okay? Why do we care less about your limbs?
Can live without that. Critical organs are in the torso.
Well, that's one reason, obviously, yeah, critical organs, heart, lungs, spleen, liver, what else?
Another thing is usually we'll have several bleeding from the limbs.
Yeah.
So we go to one anyway.
Yeah, so if you've got important bleeding from the limbs, you're probably here already. Agreed. Yeah. So someone that's got a leg missing, you pick them up already up here. Yeah. So we don't need to worry too much about limbs. Penetrating injuries to heads.
No,
Why do we care about that?
that's an honour.
Yeah, they're probably not going to be alive. And if they've got a penetrating injury to the head and they are alive, you can just worry about everything else because whatever's gone on in their head at that point doesn't matter.
So penetrating injury is mainly front to back. Like for example, if someone has talked too much and got a shot here,
Yeah.
or from here, is penetrating injury.
Penetrate, yeah.
But it's not sending us to.
But he'll either hopefully be walking,
Yeah.
severe bleeding, talking, and say if it's not penetrating here, so penetrating front and back, yes, there's still a P1, and that goes back to your question about what we do about chests. You recognise they're sick and they become a high priority.
I've got to ask.
Yeah.
You wouldn't take these out of the wrappers because why would you? The time it takes and they work without them.
Yeah.
What are they in wrappers? Because you're not going to reuse them, are you?
No, you shouldn't. But what it does do is probably, and I don't know the exact answer, it stops you using something you would use for training as live, something you would use for training as live kit. So if you unwrapped it to use it for training exercise, you've got to buy more, put them back into a live kit.
If you're doing your 10-second triage,
Yeah.
you've got rolls of these in your pocket, so you're not going to unwrap each one, are you?
No.
You're going to stack it on and move
No,
to the next one.
I think it's just because it's manufactured that way.
Yeah.
Okay.
So the manufacturers do it like that.
And if you then decide to use it for training, you take it out the wrapper and you'll then put it in a live kit and that's fine.
Because they will want to put their brand in. On the back of it, they'll do it anyway.
That's on the packet, not the strap.
Yeah, it's in the pack.
Okay.
Oh, that's nice, it's on the strap.
Yeah.
Okay.
That's what I was. I'm sorry.
Yeah.
They're quite
Yeah,
tight
yeah.
things.
Go. Okay. So you've got someone that's not walking, they haven't got severe bleed, they are not talking to you. What's the next thing you need to worry about? Are they breathing? So are they breathing? Is the airway open? Or are they breathing? Yes. No. Open the airway if you can. So if they're breathing, yes, place them in a recovery position. They are also P1. Yeah. If they're not breathing, and you open their airway and they breathe, they come up here. If they're not breathing and you open their airway, you still place them in the recovery position. Okay? And you give them the silver designation, not breathing. There's a little caveat under the bottom of that. Can anyone read that? Yeah. So what does that mean then?
If you've triaged everybody else, and you're able to, and nobody else is taking priority, and you've got the manpower and ability to do CPR.
You can do CPR, yeah. So this, to my mind, if I'm honest, is a little bit of a legal cop-out because it doesn't really say, it doesn't really define what resources you would need, how much you would have to have. Do you resuscitate that person versus that person? It just gives the makers of this a little bit of a way of saying, well, if you feel like you can achieve something.
It's a judgment call.
Yeah, it is a judgment call.
So it depends on the scenario as well. Like if the event's still unfolding, you've tourniqueted people, and actually the next best thing is to try and move that person away from the site, you'd then probably go back to those who are still in danger but clearly alive and try and remove them, wouldn't you?
Yeah, yeah. And there is a survivor from London, not London Bridge, online, July 7th, who I'm assuming made it above ground before he collapsed and died. He was one of the first patients that one of the first crews met. Again, I think all day. They didn't know there was anyone else, didn't go further in, saw that he was dead, started CPR, put him on their truck and then took him into the Royal London, which is 3-4 minute drive down one way system, and he survived. And by the letter of the law with major incidents, he shouldn't have got CPR and therefore wouldn't have survived. So with everything there are caveats. But if you're doing CPR on 15 people, which is what happened at
London, the arena,
Manchester Arena and Russell Square on a bus. So there was a lot of activity going on for 3 specific recesses. Lots of effort put in, and all 3 had non-survivable injuries. And at Manchester Arena as well. Arguably, that's not the right thing to do. You'll only be ever proved right or wrong in the aftermath of all of it, when people pull it apart, no information you don't know, look at it, and then tell you did it wrong.
Both of those scenarios were above ground, some resources were able to get to the patients quicker as well, weren't they? It's access.
Yeah. Okay. So why are we putting everyone in the recovery position if they're not breathing? Is that the reason?
They might get back to it.
Yeah. So how long is this supposed to take you in total?
10 seconds.
10 seconds, yeah.
10 seconds.
If they're not breathing once every 3 seconds, theoretically, once every 3 seconds, once every 11 seconds, you've moved on already and you haven't noticed they're breathing, right? So there is a tiny chance they could survive. Putting them in the recovery position may help that. Okay. So everyone that isn't breathing gets put into recovery position, irrespective of what category you give them. Yeah.
And also they're one stage ready for the next person, because all of this is to help identify for the rest of the help when it arrives to
move
identify
forward.
help forward.
And so if we've got someone lying on their back talking, well, it still could be a P1, but actually, as you go into a hot zone, you tend to deal with stuff geographically, so you get the first person that's closest to you, you look for the first P1 that you can see, and that's the one you take. You don't scan for the P1ist P1, you just take the closest one. If we're really Gucci, and you've got advanced teams, and this is what the national guidance is probably going to move to, you'll have a clinical lead, so someone of my level in the hot zone, who is picking the P1ist P1s, and they will direct which P1 moves first. I'm going to make a decision about all of these ones. But that depends on where you are. That's what, there was an attempt to do that in Manchester. There were 2 advanced paramedics at the scene. One of them stayed back outside the arena, one did go in. He wasn't particularly followed up by anyone else, which was unhelpful, but that's what they attempted to do at Manchester Arena. They were let down by the system that was coming in behind. And then, I think it's on the back of that chart? Yeah. You've then got an ability to count or to tick off the P1s as you, or P2s or P3s as you go along the triage, so then you've got a total count. You don't need to try and keep count in your heads, just tick them off as you do them. And then if you split into 3, 4, 5, 6, 7 teams, you can bring them back to a main point and tally up all of your numbers and then produce a methane. So a report that tells us it's a major incident, and you confirm it or decline it, the exact location of where you are, the type of incident, so that generally will be an explosion, train crash, marauding terrorist,
tall building fire.
yeah. What hazards are there? So again, that will vary, and those hazards are known or assumed. So, for example, Manchester Arena, which is where part of the problem was, they assumed that there was a marauding terrorist on site, still actively hunting and killing. They declared it as what we call an Operation Plato, so that is that type, and that kept everyone out of the room. Everyone out of the room. And it was an explosion device. So, access, so where you come in, and egress, so where the crews need to come in from, where they're going to go out from. This is probably one of the biggest things. It's really underestimated. It can make a massive difference at a scene if it's achievable, and not everywhere is achievable because it depends on the location and what road networks are like. But if you can kind of develop some sort of one-way system of in and out of a conveyor belt, you achieve much more than if you don't do that. Number of casualties, which you'll get from your triage, and then what emergency services you need, what ones are there, and what emergency services do you need. Probably, in all honesty, by the time you've done your counting, most of those are already there. Do we perform resuscitation on someone that's not breathing?
Yeah, fair enough.
Yeah, it depends. So you can or you don't have to. Yeah. Children. Under 10-second triage, any child under 2 is a P1. Automatic. Okay. The reason for that is hard to assess. Also, it allows the parent to be sick and the child can stay with the parent. If you have a P3 child and a P1 adult, theoretically you're removing the P1 child from the parent. That's problematic. If all children of that age are P1s, if the parent is walking, the child's P1, the parents are P3 walking, they still all go back. The P1 child still gets removed quickly, the P3 parent gets himself out. That avoids errors. Yeah. And if I'm honest, that a lot of that is a bit of a reflex of Manchester as well. Okay. And we talked about this. Can physiology compensate? Their physiology can compensate, and they'll look less sick than they are in reality in kids. So they'll hide stuff for a little while. If you're very good at assessing kids, you can pick it up really early, mostly in the respiration rate. But that means you've got to sit there and count it. They're going to be crying, they're going to be screaming. It's going to be up anyway. So make them P1, and they can be removed and dealt with later. And then this is what I talked about earlier. So this is what ambulance clinicians will be doing behind you, okay? So when the P3s are coming out to us, or when time allows with the ones that had TST, we'll perform a MIP, and essentially we're just looking a little bit deeper into what's going on. So we'll start to pick up physiology, so look at their breathing rate, is it between 12, is it greater than 12, oh my God, is it less than 12 or greater than 23? If it is, that's problematic. If it isn't, it's problematic. So they'll go P1 and P2. So we'll do this after, and we may well pick up that your P3 that was walking is no longer walking anymore. If they're still walking, they're still a P3 until the point they can't walk. This bit is where clinical acumen comes in. So this bit can be done a bit slower by someone that's got time to start looking at people. So the patient you described earlier has got an abdominal bleed, that's walked out and comes to me, doesn't have a catastrophic hemorrhage and is still walking, sits as a P3. If I look at them and think you're really pale, you're really sweaty, I'm going to go jump to here. I'm like, what's your breathing like? Is it quick?
Just wonder how they kept the secondary place, the non-breathing one.
Breathing no, dead, breathing yes. Which one's the worst? Oh, as in how they got there. So they could have been a P1 or P2 and carried out, and then by the time they get to you, they're not breathing. So, but yeah, they shouldn't have started.
It's not that they reassess it.
So this is a reassessment.
No, but they are reassess non-breathing. No.
When?
The MITT.
Yeah. So 10-second triage is done by anyone. Done early on, when they're removed from that area, or when clinicians can go forward, everybody will get this. So that everybody will be reassessed against this. And then the priority will be changed. Theoretically, if the TST was done correctly, the priority should never go down. It will only ever go up or stay the same, theoretically. But people could be mistriaged. People can be over-triaged in the heat of it, particularly kids. So theoretically, if they were a P2 at TST, they should be a P2 or a P1 by the time this is done. Does that make sense? Yeah. Cool. You've only got one thingy, but let's see how well we do it remembering. I'll flick back to the slide for you. I'm going to run through a couple of patients. Just very quickly, we'll do about 5 or 6 of them. Just pick the triage now. Okay? This will run on its own, you're going to have to stop it. So a male 30s, apneic, so not breathing on the ground. So male 30s, not breathing on the ground. Are they walking?
No.
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 Did I say it was bleeding?
No.
No. Are they talking?
No.
No. Are they breathing?
No.
So what do you need to do?
Recovery
Yeah,
position,
well,
silver.
Open the airway, put in the recovery position. So you open his airway, he starts to breathe. What category is he?
P1.
P1. You open his airway, he doesn't start to breathe.
Silver.
Silver. Yeah, good. Female 25, breathing rapidly, staring blankly, not following commands. So. Female 25, staring blankly, not following commands. I'm not going to run you through it.
Yeah.
No.
Well, she's conscious. You obviously said she's conscious, which is internal should be
P1.
unconscious.
P1. So about P1, P3, any other advances? You can only pick P2 or dead after that. But
Say Peter's not talking.
well, you've got 10 seconds to make a decision.
She's walking.
No, P2.
Is she walking?
You didn't say she was
Walking.
walking.
Yeah, say she's responding to you, says P2.
So I'd say she's not following commands and staring blankly.
Yeah, P1.
Definitely P1.
And this is where subtleties come into it. So if for her to walk, you need to tell her where to go and how to get there. If she's not able to follow that command, is she walking?
No, okay.
So technically she's ambulatory, right? But can you pack her off behind you and forget about her?
No.
No. So I would class her as not walking. Was she severely bleeding?
No.
No, I didn't say she was. Was she talking?
No.
No. So then what do you need to know?
Penetrating injuries, yeah.
Yeah, has she got any penetrating injuries? If she has penetrating injuries, what is she? What category?
P1.
Yeah, if she doesn't have,
P2.
yeah. Okay.
She's not talking yet.
She was talking.
Was she talking? I can't remember actually now.
No, she wasn't responding. She was staring blankly, not
Blank,
responding.
blank, yeah, staring blankly.
So she wasn't talking. She wasn't talking. So she breathing.
So I've deliberately made these ambiguous just to prove points of how this works, okay? Elderly male, breathing, mumbled response to voice, left side is immobile after a fall.
P2.
What category is it?
So it's not walking.
P2.
It's not severe bleeding.
It's mumbling.
Talking.
Fine, I'll put it there.
Everyone going for P2? Anyone going for P1?
P1.
You're going for P1?
He's
P2?
having a stroke, no? What's going on?
Well, so it's going to be in the context of a major incident, so a blast, a stab or something.
It'd be really unfortunate to be having a
A
stroke.
stroke
at
out
the
of
same time.
yeah. It's not his day for a lottery ticket. So what did we say it was?
Elderly.
So elderly, breathing, mumbled response to voice. Okay, so elderly we don't care about, then triage of age. Is he walking? We decided no, because one leg's not working.
Yeah.
Is there severe bleeding?
No.
We didn't say there was. Talking. Is
Yes.
he talking? Yes. or no?
It's mumbling.
Yeah,
It's
it's
mumbling.
Which means his airway's clear. It's not.
Okay, so if he's talking, yes, there was no penetrating injuries, he's P2. You made him P1.
Yeah.
That's
Not
the point.
talking.
Yeah?
It's
You said he's not talking. Yeah. So is mumbling talking? Is talking mumbling? Yeah.
My wife says I'm on board.
Yeah, exactly. And again, that depends on what you think they're doing. Is what they're doing talking? Is it noise? Is the mumbling appropriate? You make a
How they
decision,
say
right?
nowadays, it is Irish.
Yeah, exactly. Yeah.
But the definition of talk, presumably the talking part is the bit that helps you if you do your Dr. ABC about the breathing piece, isn't it? So if they're mumbling and it's not making any sense, it might not make sense on a normal day, might it? But
Yeah. Yeah. But the point is you've got to make a decision.
They're breathing.
Where
I think you've got 10 seconds.
That's to make that decision. So he could come out as either a P2 or a P1, right?
the second round would go up to P1 if necessary, but if it was a P1,
Yeah.
it wouldn't go down to a P2.
Probably not, no. So he might do if when he comes round, because equally he could be a bit concussed and come round, right? So, but normally they don't go down. So again, the point is, seems really clear, talking's talking, right? But talking's talking when it's talking, but when it's not talking, is it talking? You just make a decision, okay?
So
Do your best not to make just upgrade everyone.
Okay, I was going to ask, if you're undecided, it's 50-50, would you just...
50-50, I would always err on the side of caution, right? But just make an effort to try to get it as close to where you think their level is, right? And none of this is easy because you're doing it under stress, time duress, in a situation and environment that will be inherently unsafe. Otherwise, all those people would be injured, right? And your adrenaline level is going to be really high. Let's do 2 more. Teenage girl, walk in, obeys commands, move all 4 limbs, crying with a cut in her arm. P3? P3?
P4.
P4. Yeah. P3. Easy because she's walking.
Yeah.
Right?
Give it away.
The listening to following commands was a bit dubious.
Well, teenage girl, they're not going to follow commands, are they?
There you go.
Yeah. Male, 40, leg visibly deformed, breathing, obeys, that should be obeys command, moves 4 limbs, can't walk.
No. Deformed, so P2. So I don't know exactly what's the definition of deformed.
Deformed, yeah.
So where is deformed? Is what's the deformed?
Out of shape.
Just out
Out
of
of
shape.
shape. So it's
P2.
yeah, P2.
Yeah, P2 would cover today. Cool. Alright, one more. When I do this for a longer session, these have got a time thing and you just have to do it all and add it up later.
Quick fire round later.
Yeah. Okay, last one. Female 60, not breathing when airway opened after smoke inhalation.
So,
Silver. Yeah, and recovery position. Yeah, good. Okay. That is. That's it for 10 second triage for you guys. Let's get back to what we're doing again.
Is it realistic the 10 seconds when you have to deal with a catastrophic bleeds?
No.
It's not realistic.
No, it's not unless you are exceptionally well drilled in a tourniquet. I mean, I do military teaching I go out to Ukraine at least twice a year and teach out there as well, which is fast becoming redundant to be honest. But when you're in teams that are going to use tourniquets a lot, they drill putting tourniquet on themselves, on each other, in the dark, and then they can do it very quickly. For the rest of us that don't do it very often, 10 seconds isn't. Aim for 10 seconds. Get as close as you can.
But remember, you're doing it as a team.
Yeah.
So you can always leave one person doing the tourniquet. While they're doing the tourniquet, you move on to start triaging the next person.
And then you catch
And
up.
that gives them 20 seconds to put on the tourniquet.
The trick with that though, if that next person needs an intervention and you're on your own, you need to do the intervention. Because you can't then walk off because your teammate won't know what that intervention is.
A little bit off the top of it. Is
Go on.
that becoming redundant because they're trained better to deal with it, or their injuries are not?
No, they're trained better to do it, so they don't need us to tell them how to put tourniquets on.
Thank you.
In fact, they're making their own, which I've got and still because they're better than us. What we are doing out there, so one of the courses I teach on is maxillofacial stuff. So we're the maxillofacial surgeon, not because they can't do it, but they don't have the specialty everywhere, and they can't air back to the specialty, so we're having to upskill non-specialists. I'm not upskilling on the maxillofacial surgeon as I go with him in case he gets hurt.
And our nearest one for that's Norfolk Park, isn't it?
Yeah.
Yes.
Cool. Any other questions?
No,
You
Brian
try
is
and-
our nearest massive.
I do as well.
Yeah. Any other questions?
Their tourniquets are better because they're easier to deploy and secure? Or?
Yeah, so they've got a different securing mechanism, so they're a bit easier, so they latch
stick
on.
with the hooks, but it's just not.
Yeah, there's a couple of reasons why they're better. So they're better contextually. So the company that make them is called Stitch. They were really clever. So at the start of the war, there was a big campaign, which the charity that I was involved with, although I didn't do it then, was doing, and others, and it's come over here. They were doing lots of stop the bleed stuff, and so they were trying to get as many tourniquets out as they could to civilians and others. But they weren't really taking them up. People weren't carrying them around. So when I go to places like that, I carry a med pack the whole time, and it does not. It's in the same room I'm in. I go to the toilet with it. It's just everywhere because you don't know when you're going to need it, right? they were having a real problem getting civilians to do that because they were still having to live their lives in and around stuff. So they brand marketed loads of different colours, different series of them, made them collectible, pink ones, all sorts. Yeah, and it worked really well, really, really well. So that people would buy them because it was that fashion thing. Kids will buy them, which is useful and a gruesome fact of war, right? And it became really, really good. And now pretty much, I don't think there's anyone I've come across in Ukraine that hasn't got one.
Wow.
So you can get them here now as well. They've got a car mark in Europe.
Any questions about 10-second triage?
Okay.